Good morning. My name is Emma Tatum. I'm a lead policy analyst here at the board, and I'm excited to be moderating this morning's session on the future of mortality. Questions and comments are encouraged throughout the discussion and can be submitted through the Zoom Q&A box or by emailing us at events@ssab.gov. We are recording today's session and will post it to our website following the event. This panel will discuss expectations for future mortality trends in light of issues such as COVID-19 and possible future pandemics, rising deaths from drugs, suicide, and chronic liver disease, sometimes referred to as deaths of despair, and rising pediatric mortality. How long people will live to pay into and receive Social Security in the future is a key consideration for OASDI program projections. We are so fortunate to have such an esteemed panel of experts with us to discuss this topic today. I will introduce them very briefly before we begin. Their complete bios are available on our website at www.ssab.gov if you'd like to read more about them. Robert Anderson is Chief of the Mortality Statistics Branch at the National Center for Health Statistics at the Centers for Disease Control and Prevention. He oversees and is responsible for the production, analysis, and dissemination of national mortality statistics. He has also worked on issues related to disease classification, improvements in data quality, especially regarding cause of death reporting, and most recently, quantifying the effect of the COVID-19 pandemic on mortality in the United States. David Cutler is the Otto Eckstein Professor of Applied Economics in the Department of Economics at Harvard University and holds secondary appointments at the Kennedy School of Government and the School of Public Health. His expertise is in health and public economics and economic demography. Stephen Goss has been Social Security's chief actuary since 2001. He has worked in areas related to health and long-term care insurance and pension, disability, and survivor protection. Karen Glenn is SSA's deputy chief actuary for long-range actuarial estimates. She is responsible for the demographic and economic assumptions that underlie the 75-year estimates of the cost of the Social Security program. Christopher Murray is the director of the Institute for Health Metrics and Evaluation and professor and chair of Health Metrics Sciences at the University of Washington. He is a physician and health economist who leads the Global Burden of Disease, Injuries, and Risk Factors enterprise, which quantifies the comparative magnitude of health loss due to diseases, injuries, and risk factors by age, sex, and geography over time. Christopher Room is a professor of public policy and economics at the University of Virginia. His research has focused on excess deaths due to the COVID-19 pandemic, drug poisoning deaths in the United States, the relationship between macroeconomic conditions and health, the determinants of health and risky behaviors, and the causes and consequences of alcohol and illegal drug policies. And last but certainly not least, Stephen Wolf is the Director Emeritus of the Center on Society and Health at Virginia Commonwealth University, where he is Professor of Family Medicine and Population Health and holds the C. Kenneth and Diane Wright Distinguished Chair in Population Health and Health Equity. Wolf is also a clinical epidemiologist trained in preventive medicine and public health. He is board certified in family medicine and in preventive medicine and public health. Thank you all again for being with us today. I will now turn it over to Steve and Karen for their opening presentation.
Thank you very much, Emma. Hi, Steve Goss here. Just want to first of all say thank you so much to the members of the board for sponsoring this and your amazing, wonderful professional staff who've done all the work in getting all of this set up. This is fantastic. This is going to be extremely helpful for us and our office, our actuarial office at SSA, and for all the members of the Social Security and Medicare boards of trustees and all of their staff. So if we might start just jumping on here to the mortality section, which is our topic of the moment. Could you please flip to the next slide? Yes, and one more beyond that, please. So we're going to be talking about mortality. I think everybody knows here that the financing of Social Security is extremely tied to the age distribution of the population. Fertility is a major component of that, but mortality is also extremely important. You can see on these slides here is an indication of what has happened with the age sex adjusted mortality rate in the United States throughout the 20th century and so far into the 21st. It has been quite an interesting period. We had tremendous improvement in mortality through the 20th century. The first part of it, a lot of it was at very young ages, infant mortality, which is really important. In the latter half of the century, we've had some wonderful improvements after World War II, bringing antibiotics to the population, and later cardiovascular. So we've had a long ride. You can see here on the right-hand slide, which is these numbers on a basis that is not the normal, but is shown to you such that you can see the actual rate of decline is sort of indicated relatively by just looking at the sort of the slope of the lines. And the key thing here is that in the 21st century, especially over the last 10 or 15 years, mortality improvement has really slowed down quite a bit. So on the next slide, please, we can see something brought from our good friend and colleague, Bob Anderson, who will be following Karen and myself in this discussion this morning. A slide that he has put together based on the wonderful material they put together at CDC and CHS, because we look very, very careful at death rates, not just overall, but by cause of deaths. This really gives us a good indication of what has been happening so far. You can see since mid-century, 1950, that heart disease has been the driver of mortality improvement. It's been quite remarkable. However, in the very most recent period, you can see heart disease has not been improving a lot, and some of the other areas like unintentional injury have been going the other direction. So really our big question is, where are we going in the future? The past is prologue, but where we're going in the future is really the big question. That's why we're so happy to have the group of panelists that the advisory board's panel has put together for us today. So I think Karen's going to talk a little bit about the next slide.
Great. Thank you very much, Steve. And hello, everyone. We're really excited to be here today and have this discussion. So on this slide, this is just another way of looking at the trends in mortality. These are what are called survival curves. And each line in these graphs is for a different calendar year. We've got a panel on the left for men and a panel on the right for women. And what this shows you is, starting at age 65, the fraction of people who will be still alive at each successive age. So for example, I know these pictures are pretty small, but if you look at the graph for men, using 1900 death rates, which is the line at the very bottom, about 30% of 65-year-old men would live to age 80. By the time we get to 2019, which is the line at the top, we've got about 70% of those 65-year-old men would live to age 80. So what you can see is that people have been living longer. Similar pattern for women. But one interesting thing to note here is that the maximum lifespan has remained relatively stable across these years. It's somewhere in the range of 110 to 120 years. So if these trends continue, we'll see that these graphs look more and more like a rectangle. In other words, we'll see higher and higher percentages going out to older ages, and then a very steep drop off. That's why we call this rectangularizing. So the question for us is really, will these trends continue, or will there be some major medical breakthroughs in future years? Next slide, please. All right, now digging in a little deeper to some of the factors we think about. First one here is obesity. The graph you see here is courtesy of Sam Preston, who's a researcher at the University of Pennsylvania. It is a few years old. You'll see we got this from Sam in 2010, but the concepts are really still valid. What this graph shows is the percent of people who are considered obese by 4 different age groups. That's each one of the lines on the graph, and going through time, beginning in 1971 all the way through 2005, 2006. And what you can see is the clear progression to higher levels of obesity through time for all of these age groups. And one thing that's really important to think about is that the health effects of obesity tend to be most evident for those who have been obese for a long period of time. So really thinking about those cumulative effects on the body of obesity. This is really becoming a more and more important factor as obesity continues to increase at younger ages. So again, this is going to be a common theme. Will these trends continue, or will there be changes in the future? Next slide, please. Emma mentioned in the intro deaths of despair. And I know this graph is a little bit overwhelming, but what we are showing here is some of the specific causes of death that fall into that bucket. So, for example, we've got suicides, drug use, alcohol poisoning, split into very specific categories that we get from the CDC. These are the rates of death for the population under age 65. So note that it is the younger age group, going from 1999 all the way to 2021. So a few things jump out on this graph. The magenta line that you see jumping way up near the end of the graph, that is other synthetic narcotic poisoning. So you can think of that mainly as fentanyl. Obviously, that's been increasing a lot in recent years. The light green, somewhere near the middle of the slide, that's heroin, which has actually declined a bit in recent years, but it is well more than offset by the increase in fentanyl. Near the top, there's a darker red line. That's alcoholic liver disease and cirrhosis. You'll note there it increased significantly in 2020 and 2021, as did that light blue line, which is other unspecified drug poisoning. These may be pandemic effects. There were a lot of stories of people, living by themselves and having issues during the pandemic. So these may or may not be directly related to the pandemic. One thing not shown here, but it's more in the literature about these deaths of despair, is that these deaths tend to be among white adults in rural areas, those with relatively low education and low income. Again, will these trends continue? Other countries are not seeing similar patterns, so this is pretty unique to the United States. With that, I think I will turn it back to Steve for the next slide.
Thank you very much, Karen. In fact, could we just pop back to slide number 6 just for one moment? Just wanted to share with you a little bit of perspective on how discussions like we're having today are so very useful. Back in 2011, when Sam Preston, on slide 6, please. Yeah. Slide 6, we're getting there. That's the obesity slide. One more forward, please, to slide 6. There we go. Okay, when Sam Preston presented this to us back in 2011, he said this is quite interesting because in the literature, everybody was wondering, why are we not seeing increases in death rates related to obesity for people over 65 as we were getting into the early 2000s? And collectively, we all were pondering this and realized that maybe it is just like with smoking and many other things that are not good for us. It's if you are experiencing that negative factor throughout life or for a long period of time, there's a cumulative effect. And what this showed us was that at the time in the early 2000s, the bulk of people who were over age 65 that were obese had not been lifelong obese. So that helped explain it. So the kind of discussion we're having today is extremely helpful. So if we could jump forward now, please, to slide number 8, a couple forward. Great. Okay, so one of the things, obviously, that the board and we all are very interested in is the most recent COVID-19 pandemic and pandemics of that sort. You can see on this graph on the left panel where we first of all have this flattening, and this is for age sex-adjusted death rates for all ages. the flattening of our mortality line to having much less improvement starting around 2009 or 10, and really real deceleration and improvement in mortality for many reasons. But then you can see the burst that we had in 2020, 2021, even in 2022 for where we have been in mortality overall, obviously associated with the pandemic. Now you can see that we have been projecting back in the yellow and blue lines back in 2014 and the 2017 trustees reports, continued improvement in mortality, which simply had not been realized even through 2019. And now with the effect of the pandemic, this is not a good thing. One of the gigantic questions is how much longer will this pandemic persist? We know the virus has not gone away. It's in fact over the last month or two been coming back somewhat with high vaccination rates. We're seeing not as bad an impact as we had earlier in the pandemic, but the virus has not gone away. And of course, one of the other things we're really concerned about is sometimes referred to as long COVID, or the World Health Organization fortunately calls it post-COVID conditions. And we know that this will be affecting us into the long-term future. One of the gigantic questions is people who have been exposed to the period of COVID-19 and maybe even infected but survived. What will that do to their longevity expectations in the future? Might some people who might have lived to 90 only live to 88 or 85? We're expecting that there will be some impact of that, unfortunately. One interesting item is you can see on the right-hand panel here, there has been the question from the very beginning. We knew that we would be losing some people to earlier death in the pandemic, which we certainly did. It's well over 1 million, most of which are over 65. And we know that these are likely to be people who would have died relatively soon anyway. So there's a question of whether or not we'll have selective mortality, leaving a healthier, less likely to die soon population because of the people that we have lost. On the other hand, we have post-COVID conditions that will be leading to some additional compromise for those people who lived through the COVID period but survived it. So we have been assuming that those two factors would about balance out. You can see here, based on some good material from CDC, thanks again, Bob Anderson, that you can see what we've shown here is that through the period early 2000 through most of 2023, you can see the black line is showing the elevation or the relationship of age-sex adjusted mortality rates compared to the rates in the same period, the same calendar quarter of 2019, to see have we made progress relative to 2019. Obviously, in the pandemic, we have not. But the perhaps more interesting line is the red line. If we look at deaths through this period of the pandemic, excluding deaths attributed to COVID, we can see that across in total, all of the causes of death, excluding COVID, actually still led to death rates through this period on age-sex adjusted basis, elevated above the 2019 levels. So rather than seeing an improvement, which we normally expect to have on a steady basis year to year, we see that we have unfortunately not achieved that through at least 2022. So on the next slide, just a quick rundown of some of the things we're really wondering about and looking very much to hearing more from our panelists today. We're going to be paying very close attention and looking forward to discussion after. Can we expect major breakthroughs in cancer, dementia, reduction in violence in the future? That would be nice, but it may not be as easy as cardiovascular in the last century. How about COVID-19, post-COVID conditions? And how about the frequency of future pandemics with the shrunken world that we are now living in? How about obesity, as Karen mentioned, and deaths of despair? Will these be continuing at current levels where they get worse, or will we make progress against these? One thing that everybody is aware of is health spending in this country rose dramatically after Medicare and Medicaid came in. We've risen from 3% to close to 20% of GDP expended on healthcare. We cannot continue increasing healthcare spending at that kind of rate. Deceleration will occur. What effect will that have on future mortality rates? And finally, we know that we have an aging population. We have climate change. All of these will be straining resources. So as we have a shrinking share of our overall population, adult population and population as a whole being in the prime working ages, will that even put pressure on us in terms of having enough healthcare workers to be able to properly take care of in the way that we would want to folks at higher ages? So with that, I think we stop and we pass it on, Emma, to you and to our wonderful panelists that you have pulled together for today. Thank you.
Thank you, Steve and Karen. That provides a wonderful setup to the remainder of the conversation. Next, we'll hear opening remarks from each of our panelists, starting with Bob Anderson.
Okay, good morning. I really appreciate the intro that Karen and Steve provided. I think it provides some important context to certainly to what I'm going to say. And I'm going to just talk just a little bit about what we're seeing at NCHS with regard to mortality patterns briefly, and then just share some thoughts about forecasting future mortality and some of the challenges that I think that we face. Next slide, please. Here I've got excess deaths by week, and I have the data here from 2017 through August 5th, the week ending August 5th. Just a little context as to what you're seeing here. The dotted lines represent expected deaths. The blue dotted line is the estimated expected deaths, and the based on prior mortality, and the red dotted line is the upper bound. It's essentially the upper confidence limit for that estimated excess deaths estimate. And then, of course, the solid blue line are observed deaths by week. I just wanted to point out here that, obviously we've had a lot of excess deaths over the last couple of years during the period of the pandemic, and while that has subsided in 2022, and we still had excess deaths going into 2023, although starting at about week 5, which is sort of the end of January, early February, we see the excess deaths drop down into a more sort of what we would expect position. Now, these are provisional data, so the numbers could be a little bit bigger, but the timeliness of the data is such now that we don't expect that to change a whole lot. The question is, what will happen in the wintertime? Will we see a spike in excess deaths similar to what we saw last winter, driven by COVID and perhaps even by influenza, and RSV is also becoming an issue. Next slide. Here I have some cause-specific mortality, some shorter term trends than what Steve showed, but these go through the first half of 2023. So I was able to pull some provisional data from for 2022, which 2022 is nearly complete at this point. And of course, 2023 is still quite provisional, but I was able to pull from the first half of the year. You can see, very clearly the deceleration of improvement in heart disease, and a little harder to see with cerebrovascular diseases or stroke there, but you've seen some similar pattern with cardiovascular diseases more generally. Since about 2010, we've been seeing that deceleration and improvement. And then, of course, during the pandemic, we saw a bit of a spike in cardiovascular disease mortality. Now, that does seem to be improving when we look at the 2022 and the 2023 data. There are questions, of course, as to what will happen going forward. With cancer, we actually didn't see much change in 2020, but in 2021 and 2022, we did see some increases, and this may be perhaps due to interruption of healthcare access during the pandemic. It's hard to know exactly. exactly what the relationship of cancer is to the pandemic or to the virus. But there does seem to be something going on there. The cancer's been declining pretty much in a straight line. And of course, that was disrupted by the pandemic. I'll just briefly point out unintentional injuries that was mentioned by Steve. This is being driven by drug overdose mortality primarily. We only have data here through 2022 because of the nature of death investigations and the time it takes. We really don't have reliable 2023 data yet for that, nor do we have that for suicides or homicides. I'll just mention that as well. You can see the really big spike in diabetes mortality. That appears to be coming back down. That said, it's been pretty flat over the last decade. We'll have to see whether diabetes comes back down to the pre-pandemic levels or not. We're not quite sure. Chronic liver disease, this is being driven, primarily, I think, by alcohol abuse, and you can see the large increase during the pandemic there as well, although that seems to be turning down also. We did see in the initial, for suicides, we did see in 2020 a decline in suicide, but since then it has gone up. And we recently reported on suicides. The number of suicides for 2022 looks like it'll be the highest number ever, although the rate, I'll say, isn't the highest ever. There were higher rates in earlier years pre-World War II. And then the homicide rate also jumped up during the pandemic, and that it seems to be a downturn as well, although we'll have to see what we get when we see the 2023 data for homicides. Next slide. And then I'll just say something briefly here about drug overdoses. Drug overdoses, I think, are important because they really have sort of put some upward pressure on mortality rates over the years. Even when mortality was declining, wasn't declining as fast as it might otherwise because of the increases in drug overdose mortality. I have data here through March of 2023. These are annualized numbers, so each data point is sort of a 12 months ending for that month. You can see for the most recent data for 2022 and 2023, it seems fairly flat, which is, I think, good news. That said, we saw flat mortality in 2018 and most of 2019 as well. And we got a little excited about that, only to see it start to increase pre-pandemic, actually. That increase that you see there for 2020 and 2021 actually started in late 2019. And then we saw that fairly steep increase. So it'll be interesting to see what happens there going forward. That's all of the data I have to show, but I do have some thoughts on forecasting future mortality. And I think the upshot is that the pandemic's really sort of disrupted our projection modeling. It's been quite, I think, frustrating to those that do that sort of work. Some of the questions I think that we have to ask as we're sort of trying to do this is, whether the virus, SARS-CoV-2 virus, will likely become endemic. I think it is becoming endemic, and we have to think about what that will look like going forward. We do have some new variants coming around. There's a new one, BA.2.86, which is I think it may be important going forward. And then, of course, we have to take into account the possibility of medical advances. We talked about drug overdose mortality and what will happen there. Obesity was mentioned also. Will the trends in cardiovascular disease mortality continue? Will we continue to see this sort of flat curve? And then, post-COVID conditions was mentioned by Steve. I think that's important. There was some recent research in Nature Medicine that was published a few days ago, and that suggests that there may be some longer-term effects that we may not have understood to this point. And then the interruption of healthcare access and chronic disease management, especially for things like cancer, hypertension, and diabetes, and how this will impact things. So since my time is up, I will wrap it there and turn it back to Emma.
Thank you, Bob. And I'll now turn it over to David Cutler for his presentation.
Thank you very much. I was going to say thank you for inviting me, but actually I hate you for inviting me. And the reason is that you always ask me questions to which I don't have the answers. And so I feel like I'm sort of always saying things and only hazarding guesses. So I'm going to say one thing with absolute certainty, and then I'll guess at a couple of others. So if I can jump to the next slide. The thing that I'll say with absolute certainty is that in expectation, most people will die, unfortunately. So that's a very strong statement that I want to leave you with. But what I want to do in the less certain end is do two things which are related to what Steve had asked us to think about. One is talk about COVID and mortality, and then second is to talk about general mortality trends. So let me start first with the COVID and mortality. And so if I can jump to the next slide, I'm going to be very, very brief in the pictures of this, but just to give you a sense, so you can see relative to projections, mortality went up obviously in the first year of COVID, and then it sort of come back down since. And so one way to think about this is, in sort of normal COVID, we're heading back towards normal mortality, whether we make it or not, I don't know. And I'll give you a way that I think one might get at it in just a couple of slides. The question is, what is the end game? And this has come up a couple of times. So on the next slide, I've sort of tried to map out what I think are possible end games. And the one in bold is the one that I think is most likely here. Eradication is one, like smallpox. The difficulty with eradication is that the things you can eradicate are things without natural animal reservoirs. And COVID actually does have natural animal reservoirs, so we find it very difficult to eradicate those diseases. We can eliminate through vaccination and so on. It's harder because, as best we can tell, immunity wears off and the virus mutates more than do other viruses. So I think the two most likely scenarios, the sort of happier of the more likely scenarios, is cohabitation. So it becomes kind of like the seasonal flu. This is what I think is likely to happen. Although I will note, even in 2022, COVID deaths were 3 times pneumonia and influenza deaths. So it's still not down to the level of the seasonal flu, or periodic conflagration like Ebola, with possibly large and serious outbreaks associated with new variants. One of the things that we've learned is that our ability to develop vaccines is much quicker than what we had thought. So, the COVID vaccine was by orders of magnitude far more rapid than anything else. So I don't, my inclination is that something like 3 is the right model. And then the question is, what would 3 mean? And so, let's say you thought it's not going to be 3 times pneumonia and influenza deaths, but let's say you said it was just going to be an expectation, the equivalent of pneumonia and influenza deaths. Then the real question becomes, how many of those are sort of new deaths, and how many of those are just deaths that would have occurred for another reason, for another cause, but that instead occur here. And Steve, of course, brought this up earlier. And so on the next slide, I actually I haven't done this, and I thought of trying to do this, but I didn't have enough time, which is one could sort of look at the impact of the seasonal flu on total mortality. So there are, years where the flu is better or worse. There are states where the flu is better or worse within years. So one could actually estimate something that says in a year where pneumonia and influenza deaths happen to be worse for some reason, either there's happen to be worse, or if one has some instrument like, the vaccine is not quite as good in that year, or there's a particularly bad outbreak in a particular area of the country in that year. what is the impact on the total death rate? And I think I would, if you think the future of COVID is something like cohabitation, I would find something like this to be a very relevant thing to do. As I say, I haven't done it, but there's no reason why this couldn't be done. Maybe Bobby Anderson will say some reason why it can't be done. But this seems to be like at least one substantive thing one could do to try to learn about the impact of sort of seasonal COVID, if you will, of a long-term living with COVID. So that's what I wanted to say about COVID. I know there are sort of other issues associated with long COVID and what long COVID will do to longer term mortality. We don't really have a great sense of that at all. My sense, by the way, is that just as a guess, long COVID seems to be less long lasting on average than, say, long SARS was or long MERS was. So if you look at like what share of people still had those diseases a few years later, it seems to be that fewer people have COVID COVID symptoms a few years later. But that the science, that's sort of more impressionistic than it is scientific. Okay, so let me then jump in the next slide to non-COVID mortality trends. And there are any number of things going on here. There's really huge benefits in terms of mortality and heart disease treatments. There are deaths of despair, there's chronic maternal mortality, and so on. And these have not played out in the same way across the entire spectrum of people. So on the next slide, you can see a little bit about what that looks like. So this is the change from 1999 to 2015, which is the data I had close at hand, for 3 different race and ethnicities on the trend in mortality by age. And you can see that, you can sort of see the prime age higher deaths, particularly for non-Hispanic white males. And then you can see that's in a particular age group, that is prime age, say 20 to 59. If you look either younger than that, you see no differential trend for prime age white males, or importantly, if you look older than that, it looks like mortality rates in the elderly population and near elderly population were declining at roughly the same rate for all the different groups. Similarly, within the prime age male population, there are a lot of differences, and those differences are obviously very important because these are very big demographic groups. Just a couple of things to take from this. One is that there's a lot of different stuff going on. So there's not a single trend here. There's not a single thing that's going on in the data. And related to that, to the extent that it's socioeconomic, and I'll get into that in a little bit, and I suspect Steve and Steve Wolf will get into it some, as will Chris, is I think that increasingly, I am less and less happy with the idea of talking about the average mortality rate or the average life expectancy in the population, because what we've seen is a huge divergence between better off and less well-off groups, and we may need to model them separately. And certainly when we think about policy, we'll have to think about them separately. But let me give you my sense about the various trends that I see going on, and they're on the next slide. And I've given you a couple of sites down at the bottom, but I'm happy to provide more references should people want. So there are at least 4 things that I think of, probably 5 things that in the different sort of rows, the 5th one being future pandemics, which we kind of find it very, very difficult to guess about. But 4 things that we can at least know about. One is medical progress, which is very, very difficult to know. And sort of we talk a lot about that. There's the sort of good stuff like the statins and the antihypertensives, and there's the bad stuff like the new opioids. There are things about how well we do with the system and so on. To my mind, what we've learned about is that the best stuff in terms of extending lifespan is actually low-cost prevention. So if you say, what has been the most effective in extending lifespan, it's that. So I would worry less about, do we develop a new drug to treat refractory cancer of X, and more about, do we develop a ADRD prevention medication or cancer prevention medication? And so that's sort of where I would go there. And of course, healthcare access and all sorts of other things factor into that. The second one, which is really very important and doesn't get discussed so much, is pollution. The decline in pollution has had a very big effect on both length and quality of life. Third is social insurance programs. And I put in there sort of the balance between how the economy is treating people and how society is treating people. Most obvious difference between the prime age population and the non-prime age population is that social insurance is much more generous for the non-prime age population than the prime age population. And so that's probably related to the trends on the previous slide. And then there are risk factor changes, and these were also brought up earlier, where there's been a huge reduction in smoking and an increase in obesity, sort of which way those will all work out. I don't know the answer to how those will work out. On the next slide, I've given you not not my guess, but this is if when we're trying to define like conventional wisdom or something, this is from a sort of guess about what that might be. All this is just to say that there's a lot of stuff that could be on the horizon. But again, when I look at this, the thing that I want to draw my mind to based on the past is just the sort of prevention. That's where I want to think the most. So I'll just jump to the last slide and then I'll wind up there. Just keep going, please, through this and just go to the last slide. I was going to make a point, but keep going, please. One more slide, please. If I had to bet, I would bet that progress is more likely than regress because you only have to solve a problem once. But as Karen was saying, we want to think about a healthy lifespan, maybe a better bet than extensions in the oldest age. And then finally, I want to think about prevention and social structure and health as being kind of where I want to focus the bulk of my thoughts on this going forward. So let me stop there and thank you very much.
Thank you, David. Next, we'll have Chris Murray.
Thank you very much. If we could go to the next slide, please. So I'm going to give a perspective on forecasting life expectancy by state in the US. And I just want to say that it's a very data intensive approach, and it is built off a study that's now been running for 30 years called the Global Burden of Disease study that involves about 10,000 people around the world in accumulating all the epidata that's out there on diseases and risk factors and cause-specific mortality. Next slide. And if you're interested, you can go to our website, healthdata.org, and you can play around and explore the results using online data visualizations. So I'm going to go from using the Global Burden of Disease project as a base to what might it mean for the future. Next slide. So we've been trying to forecast cause-specific mortality and, of course, all-cause mortality for a long time. The first attempt was in 1997, and that was for the globe and at the regional level. And then we've started up a forecasting program, and I'll explain more what it's based on, and started publishing in 2018, and we'll have subsequent papers, and there's a number coming later this year as well on forecasts. And these are for many locations in the world, and of relevance to this discussion, these are at the state level for the US. Next slide. So the key thing here is in the model that we've tried to build, we've tried to bridge the epidemiological world, where there's a lot of interest in the drivers, smoking, for example, that David spoke about, or obesity, or drug use, and the tradition in demographic forecasting of essentially using time trends in more or less sophisticated matters, where you say, we've observed a pattern in the past, and we're going to extrapolate that into the future. And there's pros and cons for both of these approaches. And we've tried to bring the two together. And one of the key things that's in our model is that we have many drivers, like smoking is now explicitly in the model for the future, but that does require us to make forecasts of those drivers. And those, of course, can be wrong. And so there's benefits for either approach. I don't want to argue that the explicit drivers is the only way to go. Next slide. Now, this is just a visual of how we relate the global burden of disease, descriptive analysis, for example, state by state in the US, what has been the changes up until present for obesity or smoking or air pollution or temperature, which is built into this modeling, and a long list of actually 82 different risk factors, as well as other socioeconomic drivers like education and income that factor into the sort of time trends. But on the left-hand side here is the GBD analysis, and then on the right-hand side is this forecasting platform. And because of the nature of all the factors that could be influencing the trends, from pandemics to drug use and alcohol use, et cetera, by its nature, what we've built is really quite complicated because there are many of these different drivers. And of course, the more complexity you have in the model, the more scope you have for getting it wrong. On the other hand, when we do measure forecast skill, we are able, with this much more detailed modeling approach, to match, or in most cases exceed, the more traditional demographic forecasting approach where you don't have these explicit drivers. Next slide. So there's three parts to our model. And the way we do this is we take the exposure data for all the risk factors. We take systematic reviews of the relative risk of mortality by age and sex for each of those risk factors, and we remove the effect of risks from the past. So we have an underlying trend that's not explained by smoking and air pollution and obesity, et cetera. And then that underlying factor trend, we try to explain with socioeconomic variables. And then we have a third component, which is an autoregressive component that helps the model perform and capture things that are not in steps 1 or 2. Next slide. So here's just a visual of all the risks that go into our model. And in some cases, because they have a dominant effect, less in the US, we also have some interventions included in here. So vaccination is included, as is antiretrovirals for HIV. And as we get more and more data on the coverage of certain interventions, we can include those as in this list of drivers that go into the model. But I think in terms of the early discussion, we are trying to capture climate change. We are trying to capture obesity. We are trying to capture, the drivers of things like drug use, as well as all the other things listed here, like the 4 factors that David was referring to as promoting progress are implicitly here or explicitly here. Next slide. Now, I'd love to report on skill. We've adopted what the weather community does, and now trying to report on forecast skill. That is, how much better than a baseline model you are at forecasting, and where in this case, the baseline is just constant rates. And we have done that in the past. Our previous version of the model published in 2018, we did report on skill, but for the current version, which will be published later this year, I don't yet have the results to show you on skill. It's very interesting when you look at skill of people's forecasts. There's a lot of models that don't have any skill. And so it's sobering when you look at forecast skill, and that's true for economic forecasting, COVID modeling forecasting, which we're very heavily involved in, or in this case, demographic forecasting. Next slide. Okay, so here's the main result, bringing everything together. These are state-specific male and female trajectories of life expectancy. You can see the rise that was occurring and then the flattening out that Bob has spoken about, the big drop in life expectancy due to COVID. And then you can see our forecast, taking all these factors into account, has quite modest improvements. And in the case of females, around about mid-century, the sort of consequences of obesity, drug use, combine and suicide in some age groups to actually stop expansion of life expectancy. So and there's also a flattening, but not yet quite a decline for males expected as well. So our forecasts for the future, taking all these factors into account, are far less optimistic than what we would have said if we'd run these models up to 2010, before the sort of essentially the obesity wave caught up to cardiovascular disease in the US and has led to the flattening of cardiovascular disease. And in fact, in half the counties in the US, cardiovascular disease deaths are actually going up already. And not coincidentally, those counties are the ones where the obesity epidemic is farther along. So that's our take on what might be coming. Of course, if we were to show you the uncertainty intervals on these, they're appropriately very large. Thank you.
Thank you, Chris. And now I'll turn to Christopher Room.
Hi, thanks. Thanks for having me here. Very interesting panel discussion. If you go to the next slide, please. So I'm going to talk primarily about the whole notion of what are sometimes referred to as deaths of despair, and then I'll talk a little bit about heart disease and obesity. So you probably all heard this term deaths of despair. This was formulated by Case and Deaton. And what they are referring to primarily when they say deaths of despair, that's deaths due to drugs, suicides, and chronic liver disease. They actually mislabel that as alcohol. Alcohol deaths are much broader. And in what I will show you, I'm actually going to use a broader definition of alcohol deaths. They came up with this really initially as an explanation of rising mortality rates among midlife whites that we saw starting around the turn of the century. I'll note that despair is not defined, but that's a hard job. The question is this a useful concept? And my argument would be, at least at the current state of understanding, no, that it actually conceals more than it reveals. And that if we look at the components, we can make much more progress. Next slide, please. So this is showing you age-adjusted mortality rates for the three components of what are referred to as deaths of despair. Again, I'm using a broader definition of alcohol. A couple of things to note here is that the patterns are quite different. So the notion that they're caused by the same thing or that they have the same source isn't obviously true. We would also see this if we looked, say, at variation across states or across groups. We're going to see quite different patterns. And certainly if we look at the growth, drug deaths are the key. I mean, there have been growth in suicides and alcohol deaths. Some of the alcohol pieces was mentioned, maybe a COVID effect, but that's swamped by drug deaths. Next slide, please. So you can see here what I've done is normalize these. So 1999 is 100, and this shows this very dramatically. Drug deaths have gone up over 500%. The others much less. Next slide, please. So just a couple of points to mention in terms of this notion of deaths of despair. One thing you'd want to ask is, why weren't non-whites affected until very recently? So the notion of deaths of despair, as Case and Deaton proposed it was the cumulative effects of a set of things, economic and social factors, that have been going on since the 1970s. And in fact, they argued it was not a specific effect of specific economic downturns, but rather this broader set of things going on, really starting in the 1970s, if not before. And it is very difficult, at least for me, to see why those same factors would not have been affecting non-whites, or at least that the timing was very different. So non-whites actually saw a big increase in deaths during the 1990s, some of which was probably associated with the crack epidemic, but then not after that until very recently. And interestingly, what you don't hear about is that deaths of midlife whites were actually falling in the 1990s before this increase. And so those same social factors were going on. So why did, what was the timing? Next slide, please. So I'll come back to say a little bit more about despair, but, and this you've already seen. I will note that a lot of the increase in life expectancy and reduction in mortality was due to declines in heart disease mortality, which has been discussed as flattened in recent years, particularly since around 2010. I think David had a lot more to say about that than I do, but that is clearly one of the key factors. Next slide, please. Now, I don't want to say that there isn't a potential role for despair, or maybe we should call that poor mental health. So this is showing you evidence from the behavior risk factor surveillance system on the number of days people were reporting being in poor mental health in the last 30. And so the green line here is showing you the number of days. And then the orange and blue lines, and these are, look at the right axis, are showing you the probability of having at least 15 days of poor mental health in the last 30 days, or of all 30 days. And you see that all of these are increasing over time. So something appears to be going on in terms of worse mental health. Next slide, please. So this is showing you the same information, slightly different in two ways. One, I've normalized this to, so 1993 here, the first year I look at, is equal to 100. And you can see, I mean, this is really quite rapid growth. It's actually particularly rapid at the kind of more severe, at the all 30 days or the greater than 15 days. And the lighter dotted lines there are actually showing you adjustments. The original ones are just raw numbers. These try to adjust for things like age and population changes. It doesn't change the story. So the notion that something bad is going on with mental health, I think, is quite plausible. How that's related to mortality rates at this point is unclear. Next slide, please. So I want to conclude here by talking a little bit about the dangers of rising body weight. And so here what I'm showing you are, this is data, NHANES data, starting in 1999. So these are 2-year intervals. So like 2000 is 99, 2000, going to 2018. We don't have great data during COVID, and the most recent 21-22 data have not been released yet. But the first thing you notice here, and this is not a surprise, is that all of these, all of the measures of body weight are increasing over time. That is well known. You'll also notice, though, and this is hard to see in this slide, I've actually done more divisions than we normally see. 25 is overweight, 30 is greater than 30 is obese, 35 is class 2, and 40 is class 3 obesity. I'm actually showing you 45 and 50. So these are, really severe overweight. Next slide, please. This is showing you how all of these, again, normalizing to 99, 2000 is equal to 100. And what you see here is the fastest increase by far is in the most severe measures of obesity. And one of the things that I think has not received enough attention is when we look at, certainly if we look at being overweight, the mortality risks seem fairly small. Even if we look at what, is obese. So if you look at somebody who, say, has a BMI a little above 30, my reading of the literature is there are probably not major mortality effects of that, although, it may well be the issue that was raised earlier, if that's sustained over a lifetime, that could be an issue to worry about. But certainly when we get to these extremely severe measures of obesity, has incredible health risks, and they're increasing very rapidly. I think one of the questions going forward that, kind of in this group we need to struggle with is we have not had effective treatments for these in the past. That is, if you look at changes, if you look just projected trends out in a sophisticated way, not a lot of deviation from those. We do have some new treatments, specifically some of the new medications that may actually kind of bend this curve, and that's going to be really important to see. All right, thank you very much. I'll stop there.
Thanks, Chris. And last but not least, Steve Wolf.
Thank you. Good morning, and a pleasure to join this esteemed panel. I'll try to be quick so we have more time for Q&A. If you could go to the next slide, please. So this is a slide showing U.S. life expectancy relative to 16 other high-income countries. The red line is the United States. The dark black line is the mean life expectancy across those 16 high-income countries. And this is plotted through 2021. So there's several things to point out here. Obviously, you can see the effects of COVID-19, during which the United States experienced a devastating drop in life expectancy. Other countries also took a hard hit, but you can tell that the United States loss was considerably greater. But what I wanted to emphasize more is the long-term trend here. you can clearly see a dramatic problem in the United States in terms of its performance in life expectancy at birth compared to other high-income countries. So a lot of the data you've seen already is focused on age-adjusted all-cause mortality rates, and we could go through the similar exercise with that. But the point to be made here, and my main thesis, is that unless we address the root causes of this, I don't think we're going to see promising progress with either life expectancy or mortality or longevity trends going forward. Next slide, please. Several comments have been made about the decade preceding the COVID-19 pandemic. This is another variation on the same thing. We saw something happen around 2010 where all-cause mortality rates in the United States began to stabilize or flatten. And as I'll talk about in a minute, increase in certain age groups. Headline news from 2014 to 2017 was that the US experienced 3 continuous years of decreasing life expectancy. There was a problem already underway before the pandemic came along. And so when we talk about whether we're going to get back to pre-pandemic conditions, it's important to contextualize that if we end up back at pre-pandemic conditions, we're still in a pretty bad place in terms of the standing of the United States. Next slide, please. I want to focus some attention, which I think David Cutler had a slide that began to speak to this, about what's happened to the young and middle-aged adults of this country. That a lot of this trend that we've seen in the mortality rates in the years leading up to the pandemic was driven by an increase in mortality among young and middle-aged adults, 25 to 64 years. This was the subject of a 2021 report by the National Academy of Science, Engineering, and Medicine, which looked in detail at the reasons for this. Christopher Room mentioned that the mortality rates were decreasing like we want them to in the years preceding this, and then the all-cause mortality rate began increasing. The cause-specific mortality rates responsible for this trend began increasing much earlier. The NASM report that I mentioned identified 4 major causes for this increase in midlife mortality. Drug overdoses was obviously the leading one. Secondly, suicides, alcohol abuse, and cardiometabolic diseases, which was a term that the committee used to refer not only to trends with heart disease, but also with obesogenic diseases like obesity and diabetes. And so you're hearing a theme in these presentations that this trend with obesity and heart disease is a major player in trying to understand what's going on, certainly with the pre-pandemic trends that we're showing here, but also in trying to forecast what's coming down the pike. I want to endorse Dr. Room's point that we should stop using the term deaths of despair. It's very problematic. I do agree that despair is a problem in this country, but it's not a clinical term. There's a lot of proximal causes for those deaths that have little to do with despair. And that it's much healthier for us to talk about what are the specific causes of death that we're referring to, and then to dig deep into the root causes for those, rather than quickly labeling them around that particular name. Next slide, please. I also want to take a moment to draw attention to the pediatric population. In David Cutler's slide, where he showed the increase in mortality in the midlife age groups, you saw that the younger age groups and the older age groups were heading in the right direction. That was the sort of bright spot in the years preceding the pandemic. Obviously, during the pandemic, mortality rates in older adults increased dramatically for obvious reasons. What's worrying, though, is that the age-specific mortality in the pediatric population is now increasing. In the NCHS report that came out last December, reporting final mortality data and life expectancy data for 2021, the report noted that every age group above age 1 experienced an increase in all-cause mortality. This slide is showing you all-cause mortality for ages 1 to 19. It's showing a dramatic increase during the COVID-19 pandemic, but it was actually driven by factors that began many years earlier. And the significance of this is, just to put it in plain English, if all-cause mortality is increasing at ages 1 to 19, that means the probability that our children will reach age 20 is now decreasing. So I think our thinking about longevity and life expectancy trends has to give some serious consideration to what's happening in the younger population of this country. This trend that you see on here was also driven by 4 major causes. One was suicide, which began increasing in 2007 in the pediatric population. So this is a longstanding trend. Second is homicide, which began increasing in 2013, with most of those homicides involving an adult killing the child. The third, drug overdoses, which began increasing before the COVID-19 pandemic, about 2019. And then finally, transport-related accidents, which began increasing during the pandemic. Whether that particular cause of death will continue to be an issue in this age group remains unclear, but the persistence of the other causes of death prior to the COVID-19 pandemic raises serious questions as to whether we'll be continuing to deal with this problem going forward, even when COVID-19 ceases to be our major concern. So I'll stop there and look forward to the Q&A.
Thank you, Steve, and thanks to all our panelists for your presentations. A lot to think about and many places we could take this conversation. Steve and Karen, I want to start by giving you an opportunity to react to anything we've just heard or pose any initial follow-up questions to our panelists or the group, and then we'll go to board members after that.
Well, thanks, Emma, and all the people that you've invited on the panel and their wonderful presentations here. Let me just start first, and then Karen, I'm sure we'll have much more to add. This was really a wonderful presentation here, because what we have always thought about, and this speaks a little bit to Chris Murray's concept of skill and forecasting, what we have always struggled with is it's great to gain a great understanding of what's happened in the past and the conditions of the past that have contributed to the data and the trends that we've seen in the past. But the real challenge is to imagine, to try to foresee, how will those conditions be in the future? Will the conditions be exactly in the past? If so, great, let's get out a ruler and develop our projection over past trends. But if we see conditions being different in the future, then that is really major. And all the panelists here have shed tremendous light on that. I think that the great questions we have really are, obesity. I think several, I think everybody has really addressed that in this rising body weight mass, obesity in the future. And in the prior century, we were struggling with having adequate nutrition for everybody. And now we sort of, we still had that to some degree in some of our population, but now we're over nutritioning perhaps. And that's a real serious issue for the future. I guess the question really to the panelists is, do we see this continuing, or do we think we're public health, announcements? Are we going to continue to have too much candy, too much things that are make us obese, and that's going to continue to have issues in the future? It looks like Chris Murray's University of Washington projections are assuming that there will be some of that. The other, of course, is the drug abuse, and our sense of the drug abuse early on, a lot of it was over-prescribing, but since then it's gotten to be much more than that. And I'm wondering, what the panelists are thinking in terms of things like, fentanyl and similar that are not prescribed drugs that then become available in the population. Is this going to continue to be a problem as it is, get better, or get worse? So this really is, the gigantic question is not just to have a model, as Chris Murray and others have mentioned, but what are your inputs? What do you assume will be happening in terms of your dependent variables in terms of pushing us into the future?
And Steve, does any one of our panelists want to respond to Steve on any of those points?
I'll just jump in on the drug overdose part. Historically, most drug overdose epidemics have been self-limiting because people don't really want to die, and policy comes in cuts back on the substance, people decide not to take it and so on. So my thought sort of for a while was that like many things, drug overdoses would be self-limiting. Obviously 30 years is a long time to not be self-limiting, but we shouldn't forget that there are factors that will work in the other direction. Like, people will get used to what's going on and decide they want to avoid those situations. So it over my long-term projections, I don't like have it go out, continue on, because that just seems absurdly different from past epidemic experiences.
So
But even David, even if it doesn't continue rising, will it stay at about the same level, or will we drop back? It looks like Chris Room has an answer, hopefully.
well, I don't know. I don't have an answer. I have some thoughts and also a thought on obesity. So, clearly, yeah, what started, or a major driver of this, was overprescribing. That is not the major driver now, although certainly some of the, things that came from that can be what we're seeing. I agree with David in the sense that I don't think the trends can continue, the rapid rise. I just don't see how that can continue. What is less clear to me is, the levels, and can there still be some rise? I mean, fentanyl has turned out to be just this, horrible, horribly dangerous drug. And so far, I don't see that we've gotten a handle on it. But so I don't know, whether we have some modest growth, we stay where we are. I mean, we'd like to think it's going to fall, but I haven't seen evidence. I want to say on obesity, so I actually did some projecting about 20 years ago of both obesity rates and severe obesity rates, and recently looked at how that did. And it was a fairly flexible projection exercise, and it did really well. And the bad news there, I mean, really well at predicting. And the bad news there is that suggests if things continue as they were, these kinds of projections, I'm actually in process of pushing them out into the future, but it suggests rapid increases in obesity, and particularly in severe obesity. What I do think, the thing to watch is we do, for the first time, seem to have some treatments that are maybe effective. And is that going to change this, and how? And so I would say over the next 2 or 3 years, looking at what happens to kind of really severe obesity when we have these new drugs, is that changing the trends? That's going to be really interesting to look at, but it's too soon to tell as far as I know.
Steve Wolf, you have your hand raised, and then I see Nancy's unmuted, so I didn't know if she had a question after that.
Sure. I wanted to respond to the question, also talking a bit about the trends with heart disease, but coming back to obesity. A lot of the data that we've shown in the panelist presentations is looking in aggregate at heart disease. But when we start decomposing heart disease mortality by cause, we start learning some things as to what's responsible for the flattening of that curve. And one of the clues to what might be going on is that there are certain forms of heart disease mortality. I'll use hypertensive heart disease as an example, where we've seen an increase in mortality. There's a number of different causes of heart disease that probably have obesogenic origins that may be responsible for those increases, but finding out why those forms of heart disease are claiming more lives, I think, is going to be important. I really, as a social epidemiologist, my training is to look upstream to try to understand the factors responsible for these conditions. It's as if we have an airplane that's had an explosion in its fuel tank, and we're trying to predict how likely it is for the plane to complete its flight without having any discussion about the fuel tank. So when we think about obesity and its persistence, despite any number of diets and drugs being thrown at it, we need to go upstream to think about what are the drivers responsible for that. So anecdotally, the fact that obesity rates are higher in lower income individuals and households, if you are a family that's trying to make ends meet, going from paycheck to paycheck, and healthy foods of the sort that doctors would recommend are extremely expensive and outside your budget, but there's a density of fast food outlets where you live, and for $3 or $4 at McDonald's, you can feed the family, that's what you're going to do. We have a food industry that has made high calorie dense foods relatively inexpensive. So that has resulted in excessive caloric intake in the low income population. Dealing with the economic circumstances that are driving people to those choices is part of the solution, is part of looking at the ruptured fuel tank. I'm not optimistic that these trends are going to reverse themselves unless we start dealing with those root causes.
Thanks, Steve. And Nancy, I see you're on camera and off mute, so I'll recognize you first and then I'll go to other board members.
Thanks. So I was actually just jumping in, waiting for the board portion because I've got lots of questions. This has been so very, very informative. As I say, I've got lots of questions, but let me start with one so that I don't monopolize and give the other board members a chance. You've been talking about general trends and these various causes, and I'm thinking about if you could talk a little bit more about disaggregating them. David did talk a bit about trends of people of color, low income. You know, I think the conventional understanding is that that while there's been a slower increase, there's actually been stagnation or even a decline in some parts of the population and more rapid rises in others. And of course, some of these factors, when you talk about cancer, that affects everyone across the board, but some of the, the drugs, other of those factors might hit certain populations more than others. So it's just sort of an open-ended question for everyone to just, for a few minutes, to talk about the differential mortality effects.
So I can jump in on a couple of things. So when we look at suicides, those have primarily been a white phenomenon. Not, I think maybe not entirely, but mostly. When we look at drug deaths, so, if we were looking in 2010, 2013, let's say 2010 or a little later, we would have said that this was mainly occurring among non-Hispanic whites. And, a lot of the reason we think was that they were more likely to be prescribed opioids, which turned out to be quite dangerous. But if we look more recently, we have seen rapid increases among non-whites, and this is partly related again as we've moved to wider distribution of heroin and particularly fentanyl. Those are affecting a much broader cross-section of the population.
Thanks, Chris. And I think Chris Murray also wanted to say something.
Yeah, we have a long-running, and now another 5 years, project with the National Institute for Minority Health and Disparities at NIH to look at not just cause of death, but also disability at the county, race, ethnicity level. And so we've started to publish from that. And, just not to complicate your task, but the patterns are very different by locality in the US and by race, ethnicity. So, there's good chunks of the US where the increase in drugs is still there, but it's quite modest. And then there are very focal places where the increase in drugs are in the thousands of percents if you go over the last 20 years. Likewise, we're seeing very different trends at that level by race, ethnicity, on cardiovascular disease, and I agree on you have to look at the specific causes. So lots and lots of detail there, and we just published an analysis of large groups of causes, and in fact, the disparities for some causes are getting larger, and for other causes they're actually getting smaller. So it's really the devil's in the detail there.
And does that correlate also with low income, with income levels as well, or Is that
You know,
something different?
income's so much harder to nail at the individual level. You have to go to other data sources that are not as rich or cover as many age groups. So we can figure that out by income level at the community level. And, you know, take, for example, obesity, where there's this sort of, at the global level, there's an inverted U relationship. Very low income, where they can't afford food or not very obese. You have the highest level of obesity at sort of, you know, the next tier of income, and then it tends to go down. But that entire curve in the US and globally has been in every income group going up. So, you know, there are these disparities in the background, and then there are these trends on top that seem to affect many groups at the same time.
Thanks, Chris. And David, did you want to say a few words before we go to Amy for her question?
Yeah, I just want to, I don't know if this is feasible at all, but I think having the Social Security actuaries explicitly identify life expectancy by some measure of socioeconomic status. I agree with Chris that probably education would be my preferred over income, would be actually quite valuable, particularly as, you know, given the need to think about Social Security reforms coming up, because one size fits all is increasingly not working.
Thank you.
Amy? Oh, Amy?
Thank you all for a really thoughtful presentation. You've given us a lot to think about, and I'm excited to see how the Office of the Actuary takes this information. We had some thoughtful questions in the chat that were also on my mind from Noah Meyerson and Hillary Waldron around the classification of death for COVID and whether or not there's any grayness in those classifications, whether perhaps someone who's classified as a diabetic death was actually a COVID death or had heart disease and then classified as COVID. So would be interested in hearing what you all are seeing in terms of research around the noise in the labeling of the COVID death data.
Bob Anderson, please go ahead.
Yeah, I can address that briefly. I mean, particularly early in the pandemic, we know that there was some misclassification, a lot of COVID deaths that were missed. And in particular, we saw a pretty big spike in the first few months for pneumonia deaths. And those were almost certainly pneumonia. It was pneumonia caused by COVID. And we think that that some heart disease deaths and some diabetes deaths in particular were also probably COVID deaths in that early period. Later, I think, you know, as you know, cause of death certifiers became more familiar with the disease and you know, better at diagnosing it, I think that this is less of an issue. There probably still are some misclassified deaths, some deaths that were missing, but I don't think it's a huge issue in the later part of the pandemic.
Chris Murray, are you trying to weigh in?
Yeah, you know, I generally agree with Bob, but I think because we've done a lot of analyses of COVID mortality, and again, looking across many countries, not just the US. And there was, as Bob said, there was undercounting early on, but certainly after Omicron, there's some reasonable evidence there's overcounting, over assignment to COVID on death certificates. And again, we see that in a number of places in Europe. We see that in some states in the US, and we can debate about the validity of that. But for example, we're not convinced that the increase in diabetes is strictly diabetes. It could be some misclassification of COVID, but likewise, there are, you know, the number of deaths reported during Omicron, because everyone was being tested when they came to hospital, they died, and it can easily end up on the death certificate. So I think it's quite tricky in 2022 to make sense of things.
Yeah, I think that's generally true. In many instances, what we do see in 2022 and into 2023 is COVID being more often added to part 2 of the cause of death section. And generally for surveillance purposes, we just look for any mention of COVID on the death certificate, but it certainly can be parsed out. You can look at whether COVID was the underlying cause or not. I don't think that that the underlying cause numbers are overreported, but the multiple cause numbers may be to some extent.
Bob, Jundev, did you have any questions for the panelists?
Thank you, and thank you very much. This is an extremely interesting conversation. I wanted to go back to behavioral health issues, particularly suicide, mental health, substance use. Is there any data that you're aware of that looks at different states or different localities that have different levels of access to substance use treatment or mental health treatment? I'm speaking from someone in Oregon who's advocated for increased access to those services over the years, and we haven't done very well. So I'm wondering if there is any data to support the improvement of mortality when there's greater access to those services.
I think there is some data suggesting that better access does lead to improvements. And I'm blanking. There are a couple studies I'm thinking about, but so I do think there is some evidence of that. How strong the effect is, I'm less clear.
Mm-hmm.
And we certainly know that, again, I'm thinking about drug treatment here. We know that, you know, the really gold standard treatment is still not nearly as available as we think it should be.
I'll just throw in that again, in Oregon, we've embarked upon a bold experiment legalizing possession of serious drugs, and there's a public debate about the effects of that. And so, of course, I'm interested in any data or support for the efficacy of treatment. So thanks.
Steve Wolf, did you want to jump in?
I was just going to say that with these issues, it's really important to take a holistic perspective. I think mental health access to mental health services is obviously a huge issue. And I do also think that there is data showing the relationship between that and suicide rates. But we also have to think about, you know, geographically, when we disaggregate the data, where these rates are highest. There is a suicide belt in the Mountain West. We need to think about access to firearms. And, you know, it's all part of a mix. The individual who becomes desperate and who might otherwise in the past have taken an overdose of pills that could potentially be reversed if they're rushed to the emergency room and so forth, or receive Narcan, has a gun in the closet, we're going to see a different outcome. So looking at the prevalence of firearm ownership and access, the increasing lethality of the firearms, along with issues like access to mental health services, as part of the holistic understanding of what's changing these rates.
Thanks, Steve. And Jagadish, I want to give you an opportunity if you had any questions for the panel.
Thank you, Amy, or rather Emma, sorry. So my question is more about the composition of the population, both in the past and going forward. Obviously, mortality incidents and risk exposures by cause of death occur differentially for different types of people. And this has been alluded to in the previous discussion, but I just wanted to put a little more flesh on the bones here. And we know demographic projections suggest that the demographic composition of the population will change rather substantially in the future. Along dimensions, of course, age and gender is, usually taken care of, but also by education, race and ethnicity, marital status, family formation, dissolution, family size, income and wealth, and so on. So my question is just twofold, well, actually threefold. To what extent are past increases in mortality by certain causes traceable to increases in the shares of the population that are susceptible to particular causes of death? And to what extent does current research take a granular view, that is, by person type along these dimensions for estimating future mortality? And the third part is, to what extent can we extend these projections out into the future? I mean, the actuaries and trustees are expected to make projections over 75 years at least. How far can these assumptions be? Ultimately, some trend rate projected for a few years has to be continued. What is the visibility into the future for these assumptions that we make? Those are my three questions. Thank you.
David, go ahead.
So I don't know if this is entirely responsive, but having just urged you to do some disaggregation, I'm leery about disaggregating too much. And the reason is, let's say you have, 10 causes of death and one of them is declining at a point in time, for the past 10 years, and then you forecast, you'll drive that one down to 0 and everything else will stay the same, and you'll conclude there's a limit on life expectancy. And of course, what that misses is that the other things change, that it's not set in stone at the smallest level that things will always stay the same. So cancer mortality wasn't declining until it was, and things like that. So I think I in general am not a fan of super levels of disaggregation, except where the data are so clear that it's really different models, like by socioeconomic status in my mind. But I don't know what others think about that. I may be in the minority on that.
Steve? Goss. You're on mute.
Thank you, Emma. Yeah, if other of our guest panelists here will have opinions on these things, that'd be great. I just wanted to toss in a couple quick things to David Cutler's excellent points about disaggregation. David, I think you are aware, and I hope everybody else is, that Karen Gutt and others in our office have put together some really important material about not just the differential level of mortality, but also trends in the differential level of mortality by lifetime earnings levels, which of course is critical to Social Security benefit levels and our projections. So we have that out, and I believe we're not too far from having an update on that with additional stuff. Another little comment about what Bob Anderson was talking about. As Bob well knows, we in our office have been paying very careful attention to excess mortality overall, but also what we refer to lovingly as PIC, pneumonia, influenza, and COVID. And early on in the pandemic, what Bob and CDC were putting out was PI, pneumonia, influenza, and then COVID got added to it. So looking at those as a group, we think has sort of helped us a little bit in understanding, sort of the implications of perhaps misreporting. I'd just say that, Steve Wolf's observations of pediatric deaths recently is a little bit disheartening, and Chris Room's points about general health is also a little bit troubling. Just two quick questions about sort of expectations for the future, because Chris Murray is specifically talking about his model showing with some continuing rise, but then a downward move towards 2100 on life expectancy is of course, any projection in the future is dependent not just on the model, but what you are assuming. So if Chris could talk a little bit about what he's assuming about the trends in the independent variables that are driving that, and sort of in the same realm, David Cutler mentioned some of the advances we've had in inoculations, like in this pandemic, the mRNA, which I believe initially was thought to perhaps be something that would be used for cancer. Of course, it leapt to the fore in COVID-19. And should we expect that we're going to have some real positive effects, to not everything negative here, positive effects from mRNA or similar in the future?
Emma, can I jump in for 1 minute and just extend the question to Chris Murray? Chris, I know you also mentioned the effects of climate change. So if you could speak a little bit more about like the way you're thinking about that, I think that would work well in conjunction with Steve's question. Thanks.
Sure, thanks. So let me do climate first, and then explain the sort of what's in driving the slowdown. So for climate, what we've done is we've looked in all the places where we can find cause-specific mortality data by day and locality. And then we construct risk curves by temperature, by daily temperature. And we then have, like everybody in that field, noticed that those risk curves move around depending on, do you live in a cold place, a medium place, or a warm place, right? So we have these risk curves. They're all U-shaped, except for drowning, which is just a straight line up. You know, it turns out that people don't drown very much when it's really cold because they don't go in the water. But bar that, there are all these U-shaped curves. And then what we take is what is called CMIP6, which is the IPCC modeling consortium for temperature, and take the ensemble of all their models. It's about 20 models, depending on the scenario. And the one that's built into our forecast currently is called RCP 4.5, which is one of the temperature trajectories for the Earth. It's the one that most of the economists and policy analysts think is most likely to occur. We also can have a scenario where what would happen if there was much more aggressive, climate mitigation, and can trace that out. In the US, temperature effects are really quite modest because there's benefits of reduced cold as well as harm from increased heat. And in some parts of the US, actually, the reduction in cold is a benefit that's larger than the harm from increased heat. In southern states, that's not true. Maybe the bigger effect related to climate that's in the models is PM 2.5, the air pollution part. And the difference between the two scenarios, what's called RCP 4.5, what we think will happen, and RCP 1.9, which is sort of the Paris Accords, is actually quite considerable for air pollution. And there's quite a lot of benefit to the US in terms of air pollution reduction and deaths related to air pollution. So how do we end up with that sort of, flattening and decline in our life expectancy? It's really the balance, Steve, of, the big drivers here. Things like, will tobacco keep going down, which we modeled, yes, slowly, but yes. What happens to obesity? It'll keep going up because so far we've seen nowhere in the world that's actually reduced, anywhere in the world that's actually reduced obesity. And then, but you can construct a very different scenario just by moving those drivers one way or another, because you've got positive and negative things that can tip you one way or the other. I think the key insight is we have some real momentum in some of the negative things like obesity and drug use that we didn't have in the period from 1965 to more recently, up to 2010. And so we have seen the balance shift towards those negative factors. But of course, technology innovation could come along and completely change that story. Like, we've seen what the GLP-1s are already doing. But if you had mass GLP-1 use, as several people have commented, maybe that'll put a meaningful dent into obesity.
Thank you, Chris. Karen, did you have any other question before we wrap?
That was it, Emma. Thank you.
Okay. Thank you so much. So we are at time for this session. Thank you so much to our panelists and everyone else participating for an engaging discussion on this important topic.